Welcome to Focus on Health, a series of educational programs highlighting current health issues sponsored by the Department of Nursing at Salisbury University. I'm Dr. Mary DiBartolo, Professor of Nursing at Salisbury University and host of the program. I welcome back Dr. Richard Bird. You are a neurologist with Riverside Neurology Associates, and you've been on the program many times.
Yes.
I thank you for coming in again.
My pleasure.
Give us an overview of Parkinson's, what it is, and of course, what causes it.
Okay. Parkinsonism is generally considered a degenerative disorder, mainly because we still don't know exactly what causes it. It was named by Dr. Parkinson, who was the first doctor who described it back in the early 1800s, hence his name. Many diseases carry the name of the describing physician, such as Alzheimer as well. It's a degenerative disorder, which is the most common form of Parkinsonism, is Parkinson's disease, because there's a few more other causes that are far less common. It's a little bit more often in men and tends to start in late middle age. Actually, the average age of Parkinson's disease is about 63 or 64, although some people can have it in their early 30s and as late as the mid-90s. It affects primarily the motor areas of the brain, where you gradually begin to lose some of the voluntary control over the tone and the liquidity of some of your joints, meaning you begin to get stiffer and slower. You don't have as much fluid movements. You get stiffer, and you often develop, but not always, a resting tremor, which is often asymmetrical, meaning it can be on one side much more so than the other, and it stays asymmetrical. It's a resting, what they call pill rolling tremor, which means it's kind of like this. Often when they're sitting there, it's a resting tremor, and when they go to use their hands, the tremors usually stop. If it starts on one side, it tends to always stay worse on that one side. It's one of the few diseases of the brain that tends to be asymmetrical. You often become much slower in your walking with more of a bent posture. Your balance becomes more impaired and you're more prone to falling, particularly backwards. You have changes in your speech. It gets much softer and flatter, sometimes harder to understand, with a stammering quality. And there's often swallowing problems that can go with it too, and some drooling, because your throat muscles get stiff, just like your arm and leg muscles get stiff, so it's harder to swallow and keep the secretions in your mouth.
Not all these symptoms happen at once. It generally starts with a tremor or the rigidity.
The most common causes to start is an asymmetrical tremor, but it can start with stiffness and slowness too. Know that they all tend to come on gradually over time, and it varies from individual to individual how gradual that is. I've seen some people at 20 years are far better than some people at 5 years. So it varies as to how long and how slow it develops. But it's a progressive disorder. It doesn't get better and get worse again. It just steadily gets worse.
And right now we just have symptomatic treatment,
Right.
no cure of any way. And of course, mention about the brain, where exactly it's affecting the brain.
Well, most of the motor symptoms in what the area they call the basal ganglia, which are deep in the base of the brain, hence the name, and are controlling mainly volitional movement and, like I say, fluidity of movement. It's not the motor development where if you had a stroke and hit other areas where you're paralyzed, you don't become paralyzed, you become stiffer and slower. There's also certain areas in the brainstem where the pigmented areas of the brain, an area called the substantia nigra, which is a fancy Latin term for the black substance because it's pigmented. And that area tends to disappear. The pigment disappears in that area of the brain. And those are some of the wiring connections to the area of the basal ganglia in the brain. And eventually it can affect other areas of the brain too, but those are the main areas.
And of course, in that area is where there's dopamine. I mean, you want to talk a little bit about dopamine?
Yes.
Because that's what the drugs, many of the drugs
Those
address.
areas in the substantia nigra particularly produce a chemical called dopamine, which is what we call a neurotransmitter, which is how the nerves talk to each other. Instead of electrical current, which is also going on, it's a chemical connector from one nerve set to another nerve set that connect with chemicals. And dopamine largely is involving the movement system. And as that area degenerates, you make less and less of it. And you can run on low for a long time before any symptoms become. It's felt that by the time the first symptom starts, your brain is already down about 80 to 85% of capacity, so that you've been running on a redundancy and a backup system for quite some time before the first symptom ever shows up. So when you first become symptomatic, your brain is already significantly depleted in this area. So a lot of the medical therapy is trying to find ways to improve and increase dopamine chemical function to improve the areas of the brain that this area is trying to connect to get it to move better. So we try to restore some of that lost chemical function to the best we can.
Do they still use the acronym TRAP to describe the motor symptoms, which means tremor, rigidity, akinesia, which means without movement, but it's more so slowing of movement, or bradykinesia, and then postural instability.
I haven't heard that term in a long, long time.
It's still in some
but
textbooks, I'll tell you.
those are the main symptoms of Parkinson's, absolutely.
And the
although I haven't heard the term, but that sums it up quite well.
It helps people remember, and the postural instability, to me, can be really problematic because of falls and the shuffling gait. And
late in the course of the disease, I tell people their enemies are falls with fractured hips, although I haven't seen as many of those out as I would have thought I would have seen, and aspiration pneumonia, choking on the food, and having it accidentally go into your lung, causing pneumonia.
From the swallowing difficulties.
Yes, from swallowing difficulties. Those are the two main enemies that get people into serious trouble, and sometimes life-threatening. Other problems can occur too, but those are the two we really have to watch out for, because falls and loss of balance and postural balance are a real problem.
And is there any average course of the disease, like when someone's diagnosed 10, 20 years, or it can vary, of course, from person to person?
Yeah. I don't think there is an average course. I've seen some people who have had it for 25 to 30 years, and I said some of them are functioning better than some of them that have had it for 5. It depends on the severity and each individual person, and why that's different we really don't know for certain. But the vast majority of people with Parkinson's disease, if they get it at the average age, will live to be their normal expectancy and die of the other diseases of old age. Parkinson's rarely kills you these days. It can, but it's not very common anymore because therapy is so much better.
Right. And the risk factors you mentioned, of course, being older, men more commonly, and family history, having it run in the family, or certain related syndromes, or no?
Rarely. Essential tremor, which is a postural tremor of the hands, which is very common, runs in families a lot. Parkinson's disease, rare. There are some genes they've identified, and it usually attacks people when they're much younger, such as people in their 30s or 40s. Sometimes those genes are more prominent. How that affects people overall is still unknown, but it's not very familial overall, unlike some of the other disorders, such as regular tremor and Alzheimer's disease, for example, is fairly genetic.
What about insecticides, and people have been exposed to pesticides and such?
Certain chemical exposures are considered as a possible threat. Those are some. Vietnam veterans, there's a lot of claims for Agent Orange. I still don't know how well that's proven, because most of the Vietnam vets are now at the same age as most Parkinson patients get it anyway. So I don't know how well that's proven, but the government's been paying off on that. Certain toxic exposures. About 35 years ago, they had a chemical that was laced in marijuana and drugs in California, which gave people almost instantaneous Parkinson's disease severely within a week. So we know that there's a chemical that can do it, but that chemical doesn't exist in free nature that we know of. So it's still unclear as to how we get it. Are you born with it? Do you get it somehow? Do you acquire it by something you're exposed to? All that is still unknown. The real driving force is unknown. Michael J. Fox's foundation is actually doing a lot of work trying to find what they call a biomarker, meaning a blood test, or a test you can do to find out whether you're at risk for getting it. Because it'd be much better if we could treat this disease when you're healthy before that 85% is gone, and to try to find out better answer to that question.
Right. Well, we've talked about the motor symptoms, the tremor and rigidity, slowness of movement, and so on. What about, it does have some non-motor symptoms, and they can be significant.
Yes, and often precede the diagnosis. Autonomic symptoms such as constipation can be very common, bladder difficulties, swallowing, lightheadedness that when you stand up your blood pressure might drop a bit, cardiac arrhythmias occasionally, that type of thing. We sometimes see memory complaints too, which is somewhat variable, but many people with Parkinson's syndromes have some mild memory impairment. A common one that can start well before the disease is loss of smell and taste. Most of your taste is actually smell.
Right.
But many people can lose the sense of smell years before Parkinson's starts. Now, not everybody who loses the smell is going to get Parkinson's disease, but many are.
And some of these non-motor symptoms can include some neuropsychiatric issues, depression and so on. Can that be common?
Occasionally people with any kind of degenerative brain disorder can have depression as part of it, both as part of the disease and your reaction to the disease, because nobody likes this. Nobody wants this. So many people become depressed because it can be a very life-altering disease. Your independence is certainly threatened over time. But many people do develop a depression, rarely any other psychiatric disorders. If it's another disorder, often it's another disease. as I say, there are other kinds of Parkinsonism besides Parkinson's disease.
Well, let's move on to treatment then. And of course, the mainstay treatments are some medications that are available.
Yes.
And I'll let you discuss some
Okay.
of those, starting with Sinemet.
Sure. Well, before we get into treatment, sometimes we have to address medications that they may be on that will sometimes cause Parkinson's symptoms without causing Parkinson's disease. Several of medications, particularly psychiatric medications, some of the older antidepressants and anti-anxiety agents particularly, and occasionally even some of the newer ones can cause it. Reglan, which is a drug which is often used for gastric motility disorders to help get rid of some of the constipation, often gives you a Parkinson component. And we have to take people off the medications to see whether this is a drug-induced Parkinson's, that we can actually clear that up. And sometimes we're very successful with that. We can get rid of it. But I've seen other people who later come back with the real disease wondering, is this just bringing it out earlier than it was normally going to do? And there's some experts who think that may happen. So when we talk medications, first we've got to find out what the medication is causing the problem. But treatment, back in the late 60s, they came out with a drug called levodopa. Now, the deficiency in the brain is dopamine, but we can't give dopamine to the patient to get it into the brain. It will not cross what we call the blood-brain barrier, the barrier between the blood vessels and the brain cells, blocks to keep toxins out. So we cannot get dopamine into the brain, so we have to go around the back door. Levodopa is a building block that once we give the brain levodopa, we can get that in, and the brain will then take that and make it more dopamine by converting it over with enzymes and other chemicals that are there to try to make more dopamine. So we can sort of raise the dopamine by giving it the building block levodopa.
So that addresses somewhat addresses a deficiency of dopamine in the brain.
For some of us who are old enough to have been there when a lot of this was going on, levodopa can be a fairly toxic drug. It causes a lot of nausea, and you have to give it in very high doses, and it can cause a lot of autonomic symptoms too, and a lot of psychiatric symptoms. And because there was so much side effects with the drug, they added a drug called carbidopa. And what carbidopa does is it blocks all the levodopa from showing up anywhere in the body except the brain. So now we can give much smaller amounts. Virtually all of it in the system goes to the brain because the other organs are not bothered much by it, because carbidopa protects the heart, the stomach, the bowels, the bladder, everything like that. So, and we stopped a lot of the nausea and vomiting. And the term Sinemet is actually a variation of the Latin term sans emesis, which means without vomiting. So they named the drug Sinemet because we stopped the vomiting problem. And it's been dramatically better over the years. And so this has been out since the mid-1970s. And it's still the gold standard of treatment. It comes in various forms. There's the continuous release form, which lasts a lot longer in the system with fewer peaks and valleys, and there's the immediate release form, which are the two most common forms that we use. And so the generics are out there, carbidopa, levodopa, because not everybody recognizes the name Sinemet anymore, because it's been generic now for quite some time. But this is why we have the combination drug, so we get far fewer amounts of the drug because it gets all in the brain, and we keep it out of the rest of the body, keep most of the side effects at bay. It's not perfect, but it's pretty close.
Well, you know a drug works when it's one of the ways they can diagnose if you have the problem.
And that helps
they give
sometimes.
you the medicine and it's effective. So, and there's some new developments with Sinemet in terms of two new ways it can be given or formulations. One is Rytary.
Yeah. They've been trying for years to find a better mousetrap with Sinemet. Sinemet has to be given several times a day, particularly the immediate release, 3 to 4 times a day, and it may last a few hours and then wear off. And the problem is it may cause this fluctuation over time, what we call the on-off effect. You get a few hours where you're good, and then a few hours where you're bad, and a few hours where you're good. And if you have to take more to try to close that up, you get more side effects. So then they came out with Sinemet CR, which maybe lasts anywhere from 4 to 6, sometimes to 8 hours. And you have fewer peaks and valleys. You don't get quite the high, but you don't get quite the low either. And it lasts longer, and sometimes has fewer of the side effects. Years ago, they tried an infusion pump, like diabetics sometimes use, to try to see if they could infuse liquid Sinemet into the bloodstream on a steady basis. For some reason, that didn't really work. They put a lot of effort into that about 30 years ago, and then it just disappeared. But they've been coming out with different forms lately. Rytary is a new one coming out that's a combination of the CR tablet, the long-acting pill, and the immediate release tablet. The theory being that, well, we can still get the benefit of the long tablet, but sometimes that takes longer to kick in. So we add the other tablet with it, and maybe you get a faster response to it, and it'll last longer. So maybe you have more on time and less off time is the idea.
It's very expensive too, I hear.
Oh,
So
all
being a
new
new
drugs are
drug,
expensive.
yeah.
And
what about
Parkinson drugs particularly are very expensive.
Exactly.
It's an expensive disease.
Yeah. And what about duopa? That's an interesting new approach.
For severe Parkinson patients, some people have severe dysphagia, meaning I can't swallow. They have severe saliva problem. They choke, they gag, they have trouble swallowing pills, they have trouble swallowing food. These people are in serious trouble, and sometimes if this isn't corrected, largely are going to die from malnutrition and its complications. So it's kind of set up for those kind of patients because it requires you have to put a feeding tube into the distal stomach and jejunum,
The lower part
the
of the
lower part of the
bowel.
body, by actually putting a tube into the stomach wall and down and running it down into the distal stomach and duodenum and jejunum, where you can then have a bag where you feed the liquid duodopa into the stomach, bypassing the throat and the swallowing. Again, sort of a continuous release because you're doing it on a
Right.
continuous basis.
Like an
To see
implanted
if that will
device.
help.
Yeah.
And that apparently has shown some significant relief for some people, but you're dealing with a group which is fairly severely compromised. And it's a very invasive procedure. You have to cut into somebody, put a tube, which can get infected, dislodge, other complications. So we're talking a seriously affected patient here whose outlook is pretty bad to start with, that you might consider doing that for.
Well, that's also a new procedure that's very
Yes.
expensive, so only a select few can do it, I guess. But supposedly giving the gel-like form of
Yes.
it into the jejunum kind of avoids some of the variations in absorption
Yes.
than a pill into
Yes.
the stomach.
They've even, I just read this week, coming out with the, well, they haven't come out with it yet, they're researching an inhaler, which apparently gets into your system and causes relief within 10 minutes. And they're looking at that to see whether this would work even better for some people that can't swallow. You inhale it just like asthmatics do, and to see whether that would work. This may be promising. Again, these are all levodopa combinations, so we're still trying to find the better mousetrap, to how this would work for certain patients to get it into the system on a regular basis with fewer fluctuations, because they really think that over time, the more you have fluctuations in your dose, the more you're going to have problems with it later.
And Cinemet does have some side effects, however.
Yes.
But some of them can be addressed somehow if you identify them.
Early ones occasionally are nightmares. A lot of people have very vivid dreams on Cinemet. Don't know if they're all good or all bad, but they often have vivid dreams. But early on, most people tolerate it very well. Later, after many years, particularly if you keep increasing the doses or the frequency, you may wind up what's called dyskinesias, which is a tendency to, you can't stop moving. You're twisting, you're writhing, your head is going back and forth, your hands are twisting, your feet, you can't sit still, you're kind of rocking back and forth. And sometimes it can be very severe. Michael J. Fox did a lot of that several years ago, and everybody thought he was, when he was doing political commercials, that he was trying to gain sympathy by not taking his drugs. Actually, what you were looking at was too much drug, because he couldn't even keep his head on camera at times. He was moving so badly. That's been largely corrected for him. But this can be a very severe problem. Once it starts, it's hard to stop, because you've got to cut back your medication. Well, then you run into the problem that it's less effective. You can get what we call on-off effect, which means it works great for a few hours, and then it doesn't work so good for a few hours, and sometimes it crashes. Bang, it just stops. Now, since Cinemet's come out, we rarely see that. Levodopa did that all the time. You can get occasionally psychiatric disturbances, hallucinations, delusions, with long-term Cinemet and higher doses, which can come and go and cause severe problems for the patient and the family, often causing institutionalization. Again, you've got to cut the drugs back.
I guess very close follow-up with your physician is very important.
Generally, my theory, and many people have always been, keep the drugs as low and slow as you can possibly do to avoid that. And often it can be avoided as long as your patient is doing well on the doses you've got them on. It just sort of depends on how the patient is doing. Some people want perfection and want all the higher doses they can get, and you have to tell them you can't do that because you're going to pay for that. Because people don't like being slower and stiffer. They want to be moving. And more people would rather be a little toxic than a little stiff. They don't care if they're fidgeting and moving, but sometimes it can really get out of control.
Yeah. It's a delicate balance, isn't
Yes,
it?
it can be, yes.
Now, there's some other drugs out there. The next class I think that's used a good bit still is called the dopamine agonist, and
Yes.
some examples of that would be what Mirapex, Requip.
And Requip primarily. Yeah, there were a few others before, but they're largely gone now. A dopamine agonist, I use the example of a diabetic who takes oral medicine to make their insulin produce, to make their pancreas produce more insulin. Same idea as giving levodopa to a Parkinson patient. When that fails, you have to give the diabetic insulin. Now, it's not your insulin, but it's a pretty close substitution for it that'll work. And a dopamine agonist, it isn't the real dopamine, but it's close enough that we can now get a dopamine mimic into the system to try to replace what, because your body can only make just so much levodopa or dopamine. When your factory begins to continually fail, no matter how much levodopa you put in there, you can only make so much dopamine. So sometimes you can come around the back door again and give a dopamine agonist to try to replace with an artificial dopamine, which oddly can get into the system even though the real one can't. And sometimes that works well too. Many people use that to start drug with therapy, particularly in younger patients. That's controversial. Not everybody agrees with that. But it can be a good add-on drug if you stay out of trouble, because it has its own set of problems with it. And sometimes the combination therapies can be quite effective if you can stay away from the side effects, which can sometimes be a problem.
I mean, what are some of those side effects that can be problematic?
Dopamine agonists particularly are prone to hallucinations, which can really limit the dose you can do. Some people, you can't go up on the doses at all because they start hallucinating. Sleep attacks rarely occur with Sinemet, but can be fairly common with dopamine agonists. And people can fall asleep at the wheel, fall asleep with what they're doing, fall asleep at the table, but particularly falling asleep at the wheel, that's not a good thing to do. People can get killed.
Yep.
People can develop what they call impulse control disorders. They start gambling. They start doing weird things, getting online with people, sexual adventures, all sorts of things that can cause a lot of trouble. I've had a few patients that virtually tried to gamble away their entire retirement plan, going to the tracks now and gambling, or going to the casinos and gambling it away, and their families are going crazy trying to stop them, and they just can't stop. They're gambling. You have to take these medications away. So in some people, this is a problem. You rarely see that with Sinemet, but it's much more common with the dopamine agonist.
Well, again, regular follow-up visits with your
it's a balancing
Parkinson specialist. Yeah. Any other drugs of interest, classes that are used?
Some other drugs that are used, and some of the older drugs, Artane and Cogentin, which are kind of anticholinergic drugs. They've been around forever. Sometimes they can help with tremor. Sometimes they can help with stiffness. They can cause a lot of dryness and some bladder problems occasionally. They're old, so it means they're cheaper, and they can sometimes be effective. We don't use them very often anymore, but when I was first starting training light years ago, that was one of the drugs we used fairly commonly. Selegiline is a drug, amantadine, which has been initially developed to help influenza A prevention, and they found when they gave people at risk, mainly elderly people with Parkinson's disease, from getting the flu, their Parkinson's got better.
I remember when that drug came out.
Yes,
it was called
Sinitrel. It still works for the flu,
Mm-hmm.
but that's Simitrel that can work. Selegiline is another one that can sometimes help boost the Sinemet. There's one called entacapone, which helps slow the metabolism of dopamine or levodopa. Again, try to find a better mousetrap. So they combine that sometimes with Sinemet, a drug called Stalevo. So you can actually get a free amount of Sinemet combined with the drug you're paying for, which is the entacapone, which hopefully will slow the metabolism so you get less of that. And maybe
well, it sounds like there's lots of options.
So again, we're looking for that better mousetrap with Sinemet. How do we get levodopa in the body longer, ever better, and cut down some of the side effects without getting really invasive or overly expensive? So they're still working on it. This has been a work in progress for years about that drug.
And of course, what works best for the patient, is always important. Everyone's different in how they respond to these drugs. Now, just briefly, there is something called deep brain stimulation that is a surgical treatment.
Yes. Many people are familiar with pacemakers for cardiac arrhythmias, where they put a pacemaker in the chest and run a wire down into the heart and help control arrhythmias, that when your heart kicks out of gear, the pacemaker corrects it, type of thing. Well, they have a similar thing now they can do with the brain. Years ago, back in the 60s, they used to do ablative therapy. They would drill holes in somebody's head and put a probe down into the area of the brain, deep in the basal ganglia, or that substantia nigra, and they'd try to freeze it, see if they could stop tremor and some of the movements. And that actually worked, but unfortunately, it's a permanent effect, and sometimes people lost the ability to speak very well and swallow, and they've run into real problems with that. So they largely stopped doing that, and then they sort of brought it back with some stereotactic radiation forms, and then they get a much better fine-tuned apparatus where they could go in and try it again, zap certain areas of the brain to try to disconnect things to see if they could restore some of the order and balance in the system. Again, that's a permanent effect. Once you've done it, you've done it. If it doesn't go right, you're stuck. Then somebody got the idea of, what if we do an electrical discharge? Instead of an ablative discharge where we cause a lesion, What if we put a wire down in there and stimulate the area instead of ablating the area? Would that work? So back in the early 1900s, particularly in France, they started doing this, where they actually put it's like a pacemaker wire deep into the brain. When I'm talking deep, it's about from the top of your skull into the brain. It's about that long, and stimulating the brain and then running the wires down under, just like, and putting in a pacemaker in the same place you do with the heart. And they found this was very effective. It worked far better than these ablative procedures. And you can adapt that and adjust it. There's several adjustments one can make. And depending on where you have it exactly in the brain, it has several little electrodes on it. You can pick the one that works the best for your combination of the ones that work the best and try to fine-tune it over a little time to get your best response. It's very good for tremor, better than medication actually. And it's primarily used for those people who have severe tremor that doesn't respond well to medications and are becoming dysfunctional. It's not good for balance. Things down the middle, swallowing, walking, balance, not so good. Out in the periphery, arms, using legs, limbering you up, stopping the tremor, it's quite good. So you have to, initially you had to be below 60. You had to have mainly tremor disease, and you still responded otherwise to Cinemet, and you weren't demented. Well, all of that is still true, except now they've taken the age requirement out. Because most people are older than 60 that have Parkinson's disease, you know, and so now it's opened that up. It used to be, you know, well, then it was 65, and then it was 70. Now it's anybody who's a good candidate, who's healthy enough to get it done, who is not demented, because sometimes this procedure makes dementia worse, and they still have to respond to Cinemet. For some reason, that's important. I'm sure why, but if they don't respond to Cinemet, and there's a few people who don't, this won't help them either. And it can be done on both sides, or sometimes just one side. Like I say, it's an asymmetrical disease. Sometimes it's only one side that's severely affected. They just do that side. And sometimes you can go back later and do it. And then you program it, and it's like pacemakers. It has a battery. You have to keep checking it periodically to see if the battery is failing, because periodically, just like pacemakers, you got to go back and replace the batteries. So initially, you have to do some fine-tuning with it. I do that. I think I'm still the only neurologist on the Eastern Shore of Maryland who does that.
But the procedure's done.
The procedures are done in Baltimore or
Hopkins
Georgetown or Washington, D.C. But and there's a lot of doctors on the Western Shore who do the programming. But I've picked that up, started doing that in the last several years, just so people don't have to drive all the way over there, and I can do it here. So, and I find it can be very helpful. Yeah. Yeah,
it seems to be effective in a certain population of people.
Side effect rate, complication rate is very low, less than 1% on average. Now, most people are going to think about that because we're talking about drilling holes in the skull and putting wires in their brain and cutting their scalps open and having a scar.
It is brain surgery,
yes,
right?
and you can see the electrodes on the top of the head. It's a harder sell for a bald man who's going to see that every day in his life, because when you grow your hair back, because they shave your head to do it, you grow your hair back, you'll cover it up, you won't see it. But people who don't have any hair are a little more reluctant to do it. But it depends on how bad they are. I've had a few people who are bald, they just wear baseball caps a lot, you know.
So that treatment is available, but of course, I've been reading about some experimental treatments. We won't talk about these too much because they're still being looked into. Something called stim band was in the paper not too long ago, being done at Hopkins. Similar principle of ultrasound that you would wear temporarily for 20 minutes every day. So that's an experimental trial.
Again, we're trying to find a better mousetrap than the stimulator, because that's invasive. We're literally drilling holes in people's skulls and running wires down into their brain with computer help and MRI help. And I mean, people are going to think long and hard about that.
Sure.
So they've been working with ultrasound, particularly started with tremor, non-Parkinson tremor, for example, because the deep brain stimulator works very well for that too. And so they're trying to find, again, a better mousetrap, and they find that some people who have ultrasound therapy beamed to the brain to try to get it down to that area can also get good relief. But again, that's an ablative procedure to some degree, but it's not invasive. You're not drilling holes and putting probes down into people's brains, so you don't have to worry about hemorrhages or infections or broken wires.
I know there's a recent article about that.
That's not out yet for general people, but it's still being used experimentally. University of Maryland, for example, is doing a lot of that.
Is that the focused ultrasound?
And that's the focused ultrasound, and I suspect that the stim band, which I've not heard much about, is probably a variation of that to try to see if they can again get both sides and find a better way of doing it, less invasive, with maybe better treatment in the long run.
Well, while there's no cure for this, there certainly
Yeah.
seems to be, some reasonable treatments that people can try, or there's a variety of treatments available, but it's important to see a physician,
Now,
specialist.
research is showing, both for Alzheimer's and Parkinson's, I could say Michael J. Fox's foundation is trying to find biomarkers. Can we identify Parkinson's long before the symptoms show up, where you have a better chance of dealing with a healthier brain, that you may be able to get a far better outcome than you do when you're dealing with a sick brain, even though it's just starting with symptoms. And they have found many people with Alzheimer's and Parkinson's with certain techniques. They can identify on PET scans and special MRI scans people who are likely going to get the disease maybe 25 years in advance. Now with Alzheimer's, there's certain biomarkers and things we can, drug and chemicals we can do with spinal taps, which is also invasive. They're looking for a blood test. They haven't got one quite yet. They got one that's looking pretty good, but it isn't out there for general use yet, because we can't do anything about it yet, even if you have it. But this is where a lot of the research on both disorders are going. If we can identify the disease as far as 25 years in advance, can we stop it then? Can we figure out what's going on then? Can we have a therapy of some kind which will prevent the disease or largely really drag it out much better than we're doing now, because by the time, like I said, the diagnosis is made, the brain is already significantly damaged. So this is where a lot of the research is going, and Michael J. Fox and his foundation are a big part of that. So
Exactly.
he's made the most of his disease, and we all thank him for this, because he's been a major player in this.
Well, I know I'm going to post some websites at the end of the program,
Yes.
because his foundation and website is not just about here's the research we're doing. It has a lot of good information about updates on research and that kind of thing, information for patients and families. And then, of course, we're going to note the National Parkinson's Foundation, which
Yes.
has tons of information for patients to print out or they have available. We have a local support group in town where, if you attend those meetings, they have lots of their materials available, including some of these booklets on medication, nutrition. There's about a dozen of them on various topics.
Exercises, diets.
Exactly,
Yes.
and that's a big part of the therapy too, isn't it? Exercise, keeping active, keeping moving.
Keep active.
So, and the other important point that the National Parkinson's Foundation is trying to make is patients have to be their own advocates. And when they go to the hospital, because things can go awry when you're in the hospital in terms of getting your medications on time, medications that you shouldn't have if you have Parkinson's disease. So they've come up with a kit that a patient can get for free from the National Parkinson's Foundation. Has all kinds of information in it to share with the hospital staff and alert them that I have Parkinson's, I need my Cinemed on time, and certain meds that people can have. And
this
just
is sometimes a problem in the hospital.
Yeah.
They don't always get their medication on time. Then they start bunching together or spreading them out, and that can cause their own symptoms. Being sick with anything will make a Parkinson patient much worse often. Bladder infection, little pneumonia, acute surgical problem will do it with medications, anesthesia, all these things. People wind up in the hospital. Many of them are not doing well. The Parkinson's, sometimes the symptoms get much worse, and sometimes people have cognitive effects, very confused, delirious, almost like they're demented, and sometimes it takes a while to restore that. So keeping the medications balanced, knowing what not to give them, what to give them, sometimes can be very helpful, because we see this often in acute illness, hospitalized Parkinson patients. Not so much on the outside,
right.
but on the inside, this can be a real problem. So I think this is a very good idea.
Well, they're generally not admitted for Parkinson's per
No.
se, but it's a very important comorbidity
Right.
that staff need to
They're
understand.
admitted for the complication.
Exactly.
I broke my hip, I have a bladder infection, I have pneumonia, or I have another problem that has to be dealt with.
And similar to
Cardiac.
Alzheimer's, staff need to understand
Yes.
what it is and what the symptoms are. And with Parkinson's, it's not just motor symptoms; it can be non-motor.
Almost all people hospitalized with Alzheimer's deteriorate because it's a new thing and they can't handle it. And they often fall apart. That's not so true with Parkinson's, but it can be at times.
Well, we have lots of information available for patients to be
I
their
recommend
own
people look into
advocates.
this site. And I give
Yeah.
most of my patients the brochure from the National Parkinson Foundation to check this out.
Exactly.
And, get their own information, be their own advocate.
Well, again, thank you so much for being back on the
I enjoy
program
this,
on
yes.
this very important topic. We can meet every so often because there seems to be new developments
Yes.
every time.
I'm hoping before I retire they cure this.
That would be great.
So I'm not going to retire for a while.
Thank you for joining us for this edition of Focus on Health here on PAC 14.